Hello, good morning. Give it a second. Get going. All right, we're getting to the end of the year here. Very exciting. People coming, people going. I think that we're not going to have Tulsi today because she's at the board review at Columbia. All right, which, by the way, Dr. Lieberman asked me to only invite the people who were imminently about to take the board. So that's why the invitation was not extended to all of you. But he assures me that when any fellow is close to their boards, they will be invited. He said there was limited space, which is why only why only Tulsi and David were invited this year. Okay. So this is from my friend Dr. Savley, who posts a lot of interesting things on Twitter, formerly X. This is a tracing from a premature infant. He describes as having a heart rate of 300 beats per minute. So what do you think is the likely mechanism for tachycardia? I'm going to go to Christina Bezdakova of upstate New York.
Good morning, Dr. Path. So looking at this BPCs first.
Having a little trouble hearing you.
Sorry, do you hear me now? I just stepped out of the room.
Oh, that's better. Thank you.
Okay. So it looks like it is SVT and supraventricular tachycardia.
For clarifying that. That's what you meant when you said SVT, yes?
Yeah, yes.
Okay. Oh, boy. All right. Any more insight than that? I would agree with that statement, although I will not give you full credit for that answer.
So it's a reentrant tachycardia.
And why do you say it's reentrant? I agree with that, but
And
very
because,
minimal credit for that.
yes,
But tell me why.
because it's arising from above the AV node.
No. Reentry can occur anywhere in the ventricle, in the AV node, above the AV node, below, with both.
Hmm.
Do reentrant arrhythmias stop and start suddenly, or do they heat up and slow down?
Oh, they stop and start. So
Is this arrhythmia stopping suddenly or slowing down?
it looks like it's
This is a
stopping
continuous
suddenly.
tracing. Yes, it stopped quite suddenly, right? We
Yeah,
go from
yeah.
300 beats per minute to 100.
Hmm.
So anything on the tracing can give you the mechanism of the SVT? Anything concerning or unusual? Like maybe near Dr. Savley's name, which he was kind enough to put in the middle of the tracing.
I mean, there it looks like the QRS is widening.
Uh-huh. What do you think about the PR interval? About does this remind you of anything?
It looks like the PR interval.
Is there like anything remotely looking like a delta type wave?
Oh, yeah, yeah. So say then be concerned if the patient has WPW,
Yeah,
the delta wave.
I think I would say rather than say I'm concerned, I would say the patient in fact has WPW, right?
Yes.
They obviously see that there is a delta wave, and the QRS is a little widened, as you said, and look at this bead is very obvious. So this is WPW, and Dr. Savley was nice enough to put also in his tracings the 12 lead of the patient. Why don't we see if Dr. Capon has any thoughts on where this accessory pathway might be located?
Good morning.
Good morning.
Good morning. So I would want to refer to the Oklahoma
Map?
algorithm to help me in terms of where this is.
Okay, I think I'll
Uh,
offer that to you.
Yeah, so first things first, I would look at, oh, thank you. I was looking it up myself too. So looking at lead one, determining if it's positive or negative, it's negative, or if V1's R over S is greater than 1.
Mount Sinai and Pediatric
And what do you
Sorry.
think? On V1,
Um,
is R greater than
uh,
S?
yes, it is.
Yes,
This
it
is muted.
is.
Both of them is muted.
I think
This
Dr.
one-
Kalis is in your background, but I understand
Oh,
it's the
so-
same space.
I'm not joining.
So that means
So it's in
that
the
it's a
left free
side,
wall.
it's a left sided, right, left free wall, and then we're looking at AVF if it's
Mhm.
positive, isoelectric or negative. So in AVF, I think it's
Positive.
positive. So that would put it in left lateral,
Hi.
or left
Yeah.
ventral.
Mine from Mount Sinai. We were receiving.
So basically then this is an example of a patient who has a left-sided accessory pathway. So Ivana, you've terminated the tachycardia and you're in the NICU, and the family wants to speak with you, and they want to know what is the natural history of this, and the NICU wants to know if this patient should be treated. So what are the answers? What would you offer as the answers to both the NICU and to the family?
So firstly, talking to the parents. So my major concern is that the patient is pre-excited, and I can assume it's a high-risk pathway given that they did have SVT. So it
Wait,
is
wait. High risk for what?
not that it's high risk, but uh, they do go into SVT.
Right. Well, they are at risk for SVT because she literally just had SVT.
Yeah.
So, but wouldn't necessarily, when we talk about high risk in regards to WPW, right, though we're really speaking about the risk for sudden cardiac arrest or sudden cardiac death related to rapidly conducted atrial fibrillation. So we really can't make any statements about that aspect, but we are certainly at high risk for the development of SVT since the
Yes.
patient literally just had SVT.
Yeah.
Okay, so let me stop interrupting you.
Sorry. So in terms of counseling the family and with the NICU, I think I would recommend starting, for example, a beta blocker such as propanolol,
Okay,
depending on what the patient's intrinsic sinus rate is, and see if they'll be able to tolerate, given that they're
so-
inpatient.
so if this is your ECG, this is the 12 lead. Is there anything about this that would preclude you from starting a beta blocker for propranolol?
No.
No, okay,
So I'd start likely propanolol,
okay,
2 per kilo per day, Q8 or Q6 dosing,
right,
and then follow the patient
okay.
and see if that controlled any future episodes of SVT. They are a
Okay.
preemie in the NICU. I'm not sure.
Any other options?
Other options that I would
Therapy
pardon me?
in regards to therapy. I agree with everything you've said. I'm just, interestingly enough, in some countries, propranolol is not that easy to get.
Got it.
So I don't know about that, about Dr. Savley's country, but what would you, if you didn't have propranolol, could you think of other agents that might be reasonable?
I suppose you could try. I mean, I don't know how old this is, and I'd be a little wary of starting
preemie.
amiodarone.
Yeah, but amio is perfectly reasonable.
Yeah.
Interestingly enough, in a lot of countries, amio is the first agent fact, I think in Ireland, amio is very routinely used as the first agent in newborns with SVT. On the theory that it's a very safe agent, it's very inexpensive, interestingly, in most countries, and it's once a day dosing. So it's very easy for parents. And since the medication is only used for a relatively brief period, meaning usually less than a year, the chances of having significant side effects is relatively low. So that would be one option. And then one could use anything else, right? You could use sotalol, you could use flecainide. I mean, I wouldn't choose either of those as a first line agent for this, but what about the idea of not treating at all?
To be honest, my comfort level of seeing a patient have a form of SVT up to 300. I obviously wasn't there to assess their hemodynamics at the bedside at the time, but I would probably err on the side of treating in this situation. But based off your line of questioning, it sounds like you could perhaps observe as well. I think it depends how long they're going to remain admitted, where you can follow them.
Well, I guess what I would say is this. First of all, I don't think you need to have seen the patient at a heart rate of 300 to know that the hemodynamics were negatively affected by that, and it's not really good for anybody. Now, you're right, there are some patients in whom this would be instantly life-threatening. For example, if it happened to me. But in a premature infant who's otherwise healthy, it's probably going to be well tolerated, at least temporarily, but generally not something we would want. The reason I'm asking the question is sometimes if we would never not treat somebody like this who, for example, was a full-term infant and was going home tomorrow. But if this, for example, was a 24-week preemie, one could make an argument that since you're in a monitored space in a NICU, that it wouldn't be unreasonable to not treat and see if the episodes don't happen again. You have the benefit of being in a controlled environment where you know that the patient will be identified rapidly in the event of SVT and will be able to be treated rapidly. That is not the case when patients go home from the hospital. So I think the only case in newborns where I am sometimes willing to not treat is when a patient is very premature and has, 2 to 4 months of NICU time ahead of them. Um, that would be the one case. Now, I certainly would not argue at all with the notion of just treating everybody who has SVT that's this fast and has WPW and such and such. I have no objection to that. It probably is, in fact, the best option, but it would not be unusual or wrong to consider in somebody who's going to be monitored for a long time to watch them. Understanding that there is a very real chance that the tachycardia could recur, but might not. So, okay. So now the family is very nervous and they hear you're a very nice doctor, and you have to tell them what you anticipate will be the natural history of their premature infant. Let's make it up for the sake of conversation, as 25 weeks gestation. What are you going to tell the family regarding the natural history of this?
So I would counsel them in saying that, as per my practice, we would treat the patient right now and follow their telemetry over the course of their inpatient stay.
Uh-huh.
Upon going home, we would follow them outpatient with regular intervals. Sometimes these patients kind of have resolution of this kind of etiology and don't require anything as they get older. Some patients also do continue to have pre-excitation that may lead to SVT. And if that's the case, we could pursue an EP study later down the line, but that's significantly years down the road. But medical management is very safe and effective. And if so needed, we could always work towards an ablation later down the line, as in
And
years from now.
so the family is very nervous about this fancy procedure called ablation. Um, Doctor, is there any chance my child could avoid an ablation? Is there any chance
Um,
it can just go away?
yes, there is.
And what is that chance? Because I'm I'm worried. I hear this guy pass and love are very dangerous. I don't want them near my child. How can we, is there any chance, is there any reason to be optimistic in any way that this could get better all by itself?
Well, I can assure you that both Dr. Love and Dr. Pass are excellent.
Very kind
In
of
terms
you.
of exact numbers, I would err on the side of the caution in this specific moment of giving an exact number because I don't know it off the top of my head. But as a premature baby, having WPW, I would imagine that um, there is a pretty significant chance that this might improve with time by a couple years of age, and that nothing would be required from an interventional standpoint.
Okay, so the traditional teaching is that if you have SVT as a newborn, the chances that the pathway or the mechanism for SVT will completely and totally resolve is approximately 1/3 of pathways will just go away completely. And this is known because in the 80s and 90s, studies were done using transesophageal studies. It used to be a thing that if you had, let's say you had SVT and you were on a beta blocker, some places would not stop the beta blocker until they did a limited transesophageal study in order to see if the patient was still inducible. And they would base the decision to stop meds on that. And so we actually have literature now on how likely it is that pathways are going to go away. And it turns out that about 1/3 of all accessory pathways that are, or mechanisms for SVT in the newborn period will spontaneously resolve on their own. We don't fully understand why that is. We think it's probably some kind of fibrotic process. But about 1/3 of the time, the pathway, even if you formally test, there's no evidence for a pathway. Another third, although they have evidence for the pathway at a year of age, will actually never have SVT in their lifetime. I'm not sure how to explain that except to say that probably maybe it's still present on an EP study at a year of age, but maybe later in life it resolves, or the refractory periods are just too close to allow it to have tachycardia. But the bottom line is that when you meet a newborn who has SVT, the general teaching is that approximately 2/3 of patients by a year of age will have no further SVT the rest of their lives. And that is the most important and powerful reason why we almost never perform ablations in small infants. There are rare cases where we have very challenging to control arrhythmias, where patients have had toxicity related to meds, where patients have other cardiac problems where SVT in combination with that problem is a lethal problem. But as I'm sure most of you have seen, it's very unusual for us to do ablations in small infants. And the most important reason for that is because we're always hoping that based on the natural history that the tachycardia mechanism will resolve spontaneously. Beyond a year of age, essentially there's almost no chance of it resolving. So what I would normally tell a parent in this circumstance is that they should be fairly optimistic that this is going to resolve spontaneously. And the goal of our treatment in the first year of life is simply to control the arrhythmia, hopefully until the tachycardia resolves on its own spontaneously. Interestingly, more recently, and it's not that recent, maybe 10 to 15 years ago, the group in Texas wrote a paper in which they essentially showed that if you have WPW as the cause of SVT, probably it's not 2/3 that resolve, probably more like 50%, meaning that WPW tends to stick around a little bit more than, say, a concealed pathway or a patient who has AV nodal reentry. But, again, if you're a preemie, I would think that a preemie has a better shot just because you're even before essentially you're earlier than you're supposed to be out of the womb, and so maybe there's a better chance the pathway is going to resolve. But the bottom line is, we would always hope that it will get better on its own. So you would generally give the family a very optimistic viewpoint, and traditionally, the treatment is usually for 1 year, the first year of life, but more recent works have demonstrated that there isn't really very much incremental benefit to treating beyond 6 to 9 months of age. That the chances of recurrence after discontinuation of antiarrhythmic agents at that range, 6 to 9 months, is pretty much the same as when you stop it at a year. And so maybe we've been a little too conservative in keeping patients on for a full year. What I have typically done is I continue to increase the dose for weight until a patient is about 6 months of age, and then I will typically just allow the child to outgrow the dose if they are not having any SVT. That isn't necessarily the right thing to do, but part of the reason I've done that is because it makes me feel a little more comfortable when we stop it that they've had at least a couple of months with a very low dose or maybe even a subtherapeutic dose. So one can feel a little more comfortable that the medicine is not as necessary. So that's pretty much what I would say there. Any questions about that?
Yeah, so with regards to preemies themselves, I know theoretically it makes sense that it likely will kind of outgrow this more so than the term infant. Is there data to support that just yet, or is that more so anecdotal?
I don't honestly know. I would say it's probably anecdotal. You know, one of the it's what's interesting is that there are certainly many fetal tachycardias, including fetal reentrant arrhythmias like SVT, that fetal cardiologists are very worried about in utero, and then never become a problem postnatally. And how does one explain that? Why is somebody who's having a very difficult time with SVT in the prenatal period get born and has nothing? Now, that's not always the case. In fact, it's unusual, but it definitely is observed. And the answer is that probably there is some element of these pathways. It might be that pathways are more common. There's probably an embryological explanation I'm not familiar with, but it is of interest, right? That there are patients who Dr. Geiger, Dr. Schrader, Dr. Stern, and Dr. Ezon are caring for, Dr. Cohn, and pretty hard to control arrhythmias, and then the child's born and they have nothing. And that's always a question that comes up. If the child's sitting in the NICU for like 3 or 4 days and has had nothing, should we treat the patient or not? And to some degree, there's an element of style in regards to that. And my general approach is that if a child had a difficult to control SVT, or if there was even a question of hydrops in utero, I would treat. Doesn't make physiological sense that the moment you're popped out of the mother's womb, all of a sudden the pathway stops conducting. So I usually will treat that patient. I might treat them a shorter period of time than I would other children with SVT, but I would usually treat. Any other questions about this?
No, thank you so much.
Thank you. Okay. Why don't we do this one? Okay, so this child comes in. I think this is a tracing from a book that one of my former colleagues, a nice man named Ehud Krongrad, who fortunately died a few years ago, was when he retired, he said, "You could take whatever books you'd like, Rob." And I just grabbed all his EP books. Dr. Krongrad was one of the first people to do EP studies in children at all in an era before the availability of ablation. So something of a pioneer. Anyway, this was in Ehud's book, I think. And so the question is, what are we looking at and how can we treat this? So why don't I ask Dr. Kalis, who I know has had a very busy weekend, but we'll impose upon her for a few moments and see if she can tell us what she thinks.
All right. So let's see. It doesn't look like we have a rhythm strip. So need to,
It's continuous, though.
yeah, okay.
So is it wide or narrow?
It's wide.
Is it regular or irregular?
It is irregular.
Is it regularly irregular or is it irregularly irregular?
It is irregularly irregular.
So if I may summarize what you just told me, we have a wide complex tachycardia that is irregularly irregular, and is it fast?
It is fast. Yeah, I think
Yeah, I mean, like, look at
it's
this.
irregular, but it is fast.
Look at this R interval. This is
Yeah,
pretty
it's like
fast. This is
almost
almost a
300.
300, right?
Yeah, yeah.
So what do you think this is?
So with irregularly irregular, I'd be worried about AFib.
Right. And how
And then if
and if somebody had AFib, could they conduct this rapidly? Is there any circumstance where they could conduct this?
well, when they're pre-excited or if they have
Mhm.
a like a pathway and they can have rapid
Yeah.
ventricular conduction.
Yeah. So that's what this is, right? So
Mhm.
Dr. Hordoff, who's another friend of mine, another older cardiologist, old time. So you guys think I'm old. These guys make me look like babies. Um, Dr. Hordoff would say, you have to recognize this. And he'd be right. So this is an irregular wide QRS tachycardia. So in pediatrics, the most likely diagnosis for this would be rapidly conducted atrial fibrillation in the setting of WPW. So now you're in the ER. Patient is actually surprisingly okay, is lying in bed, is on the stretcher, is saying she feels the palpitations, but is okay. So what do you want to do about this, Dr. Maya Kalis?
Um, so I guess we would have to treat it like we would treat AFib. So we would
Uh-huh.
want to check a TEE. Well, I guess we'd have to figure out how long this has been going on for.
Felt it
Um,
like 20 minutes ago.
oh, okay. So I guess, well, if it's been going on for like a long time, then we would need to do a TEE. But if it's only been happening for 20 minutes,
Well, let's say it was
maybe
going
we
on
wouldn't.
for a long time. Let's say it was happening. We don't know how long it's been going on. Let's say it's a
Uh-huh.
patient who's autistic and is nonverbal
Okay.
and a teenager and comes in and this is what you have. And you're worried. You don't know how long it's been going on.
Yeah. Then I would say we should do a TEE
Now,
to look for any clots.
how long do you think it would take for you to arrange for a TE and to do that, roughly, in the best world?
Mm, maybe like, I don't know, if we could really get everything together, like 20, 30 minutes or so. Like,
I think it'd be fair to guess that if it were, particularly if it was a weekend, let's say it's a weekend and I'm on call and I don't do TEs, right? We would
yeah,
probably have to
then it'd
call
be.
in one of our echo colleagues and you'd have to sedate this patient. So you'd need somebody to sedate them. And so we would probably say, let's put the patient in the ICU. And that whole process in a perfect world would take an hour, right?
Yeah,
At least.
yeah.
Do you want to leave this patient in this rhythm for an hour?
I guess not if he,
No.
I guess she's hemodynamically stable now, but with this rapid ventricular response, it can be
Right. And
dangerous.
so that's what you just said is one of the most important points, which is, sometimes we see a rhythm like this and you naturally assume that the patient will be unconscious and essentially arresting. But
Mm,
this type of rhythm, a patient can be fine. But as in all things of health related, everybody is fine until they're not. And
mhm.
this patient absolutely could go into VF at any moment. So this is a situation where even if we didn't know how long the patient was in it, we need to get the patient out of this arrhythmia. We cannot, this is a situation where the risk of dying from this is so great that we will assume the risk that there's a thrombus in the heart and that we could potentially be risking a stroke because this could absolutely degenerate into something very bad, very, very rapidly.
Okay.
So how would you treat this, Maya? So you've decided you're nervous. You're remembering that Dr. Pass said this is very dangerous. We have to treat this
Hmm.
pretty quickly.
Hmm.
So
So
I
I
would
guess,
I would describe this, by the way, as very urgent, perhaps not emergent, but
okay.
definitely something you want to get done.
Okay. Then I guess in that case, we're saying it's not emergent, but very urgent.
Yes.
Maybe we do like medical cardioversion. Like we do start the heparin
Okay.
because we're presuming there is a clot, and then would we,
Well, okay,
or
but
would we go straight for?
well, what would you medically use? What could slow this down, hopefully quickly?
We can use, I know we've used like PO flecainide. We can also use procainamide.
Right. So you would use an IV agent in this
Yeah, for
circumstance
this
because
case.
PO agent might take 20 to 30 minutes to be absorbed. And if procainamide is the traditional best agent for this because procainamide lengthens the refractory period of accessory pathways. So the medical treatment of choice would probably be proc. Another option
Okay.
might be amiodarone IV. But probably proc would be the best one. What about digoxin?
Um, I wasn't aware that that
WPW,
was,
rapidly
I,
conducted.
I don't know. I guess that was not one of the treatment choices that I think I would have
Yeah,
chosen.
digoxin is the wrong answer. Never, ever give digoxin to such a patient. Digoxin can enhance accessory pathway conduction, and instead of conducting one
Mm,
beat out of 10 at a rate of 300, they might all start conducting at 300
mm,
and be in VF very rapidly. You never, ever, ever give digoxin in this circumstance. Same thing for verapamil or any calcium channel blocker. They are absolutely contraindicated in the setting of rapidly conducted AFib in the setting of WPW. I know of a case where a doctor didn't make this diagnosis correctly, gave digoxin, and the patient arrested and died. So do not do that. This is not a case for digoxin. Digoxin, remember, digoxin and WPW in general are never given together, right? That we don't
mm-hmm,
almost never. There are rare doctors who maybe in the newborn period for the treatment of SVT will use it on the theory that AFib is very, very rare in newborns. I don't have an objection to that. It would not be my first choice, but I think it's reasonable. But outside of the newborn period, nobody would use digoxin in the setting of WPW, and for sure you wouldn't treat this particular arrhythmia with it. That would be like throwing, coals on the fire, as it were. So procainamide, but the real treatment is cardioversion, right? You could
mm-hmm.
cardiovert. How many joules per kilo would you give for this AFib episode?
I would give 0.5 joules per kilo.
Right, 0.5 to 1 joules per kilo. And you would certainly wait until you have this patient, till someone is available to sedate the patient. Although
Mm-hmm,
it is urgent, you would never, I remind everybody, we do not ever, ever cardiovert or electrically shock any patient unless they are sedated or are themselves unconscious to begin with. So if
mm-hmm,
this patient right in front of your eyes degenerated into VF and became unconscious, of course, proceed with
mm-hmm,
defibrillation. But in the absence of a loss of consciousness, always a patient needs to be sedated. I think some of you have met. I have a patient who a couple of maybe 3 years ago actually was just in SVT, but because he has IDD anatomy with dextrocardia, his QRS looks like VT and SVT, and the doctors in the emergency department, not at this institution, unfortunately cardioverted him awake because they thought he was at risk in VT, even though he was completely conscious. And he has needed therapy now for the last 3 years and has severe PTSD as a result of that episode. So never, ever, ever cardiovert anyone awake on. But again, if this patient had degenerated into VF and was not conscious, of course, don't wait for anesthesia, don't sedate, just shock the patient. So we would shock the patient, and then after that, right, the patient would then, this patient has demonstrated high risk, right, because we have in AFib some RR intervals that are very short, suggesting a high risk pathway. So this patient needs an ablation.
mm-hmm.
If the patient is not able to have an ablation for whatever reason, then needs to be put on an agent that can lengthen the refractory period of the pathway, and those would be the procainamide, possibly amiodarone, and maybe even flecainide. But really, the treatment of choice would be an ablation in this setting. Any questions about that?
Dr. Pass, in this case, I know you said it's like urgent, not emergent. Do you think you would elect for like DC cardioversion or medical cardioversion?
I mean, I think in general, the most people would electrically cardiovert such a patient. You know, if you're in an
Okay.
ER doctors are fully trained to sedate patients for this. Some doctors in the ER feel more or less comfortable doing that. And so, to some degree, I would base my decision on the level of comfort of the individuals who would have to do the sedation. This is generally an easy thing to sedate for because you don't have to do a TE. So in other words, the sedation is short and brief. And Ivana, as a critical care doctor, I'm sure you would agree that it's generally easier to sedate someone for, say, a 2-minute procedure than a 20-minute procedure. Am I getting that right, Ivana?
Yeah, that's easy enough.
Yeah, I mean, you could like give a tiny bit of propofol, patient is out, you know, and oftentimes my ICU or anesthesia colleagues will say, go ahead, do it right now. You know, like if you have this like, you know, 45-second period in which a patient is not going to feel it. But if I felt like I was in a circumstance where I couldn't safely cardiovert somebody, then I would probably try to give a big bolus of maybe 5 or 10 per kilo of procainamide and see what happened. But you have to be ready to cardiovert because it could degenerate at any moment, even while you're infusing the procainamide. So that's what I would do.
Okay,
All right.
thank you.
With that, we'll call it a day for today. Thank you very much and see you a little bit. Take care. Have a good day.
Thank you.
Bye.
Thanks.